So if any of you, have a thought on something I'm saying, or a different way to do it, we're more than open to discussing things. I definitely don't want to lecture at you, because what I find is when we do these events is like, I always learn something new myself from somebody who was commenting about, oh, did you hear about this, or did you hear about that, either product or a different technique. Like, is it Valu? You were already teaching me about something.
Oh, for the constipation?
4 hours with vitamin C regarding mercury detoxification.
Yes,
I'm like,
absolutely.
okay.
Once the mercury is removed, because you get the vapor sucked in through the gums, you want to give an IV vitamin C to help with the detoxification process of that mercury.
Within 4 hours?
It's got to be done, quickly to get it out.
See, that was my lesson, my first lesson of the day. Okay,
Yeah,
but
that's
we
good,
have
man.
we have a lot of patients that actually come to us and look like this. But this won't work actually on my screen because it's an LED screen. So, this is actually one of our patients. She comes in with a lot of metals in her mouth. And what's wrong with metals? Galvanic current. Galvanic current would drain your batteries. That's the way I explain it to patients. It drains the batteries because it creates electric charges in the mouth. It's essentially a current that will drain. And some people actually come in with symptoms. I've had patients that had symptoms on the whole side of the body just because, let's say, they had a mercury filling and a gold crown touching. And by the afternoon, she was getting a headache, and the whole side she could feel. The moment we changed those two, we removed the mercury, her symptoms went away. So it's that powerful. So actually now, she looks like this. When we see all kinds of different patients, we have patients, that are missing teeth. We have patients that come in with advanced periodontal disease, like the gentleman in the middle that now has a full set of teeth on implants. And patients that, are not even aware about what's possible today. And I think my goal today is just to share with you the different techniques that are available today in dentistry that weren't available even 10 years ago. So dentistry has gotten healthier. That's the good news. I think we still have ways to go in certain aspects, like root canal therapy. We still need research to see how well can we clean those canals. We're not 100% there yet, but I have one of my dear colleagues, Dr. Valerie Cantor. She's working on it. She's doing research, trying to see how can we hold the structure without the bacteria. Because really that's the problem with root canals. It's the bacteria that's trapped inside. But today I want to talk about some biological dental principles. Probably most of you here are familiar with biological dentistry already. But also when it comes to periodontics, we're into changing the microbiome of the mouth. And that's the big topic for us. And a couple of medical conferences that I've been to, I know that's a big subject for you as well. Where are we with cavitations? What's the best way to remove them? And maybe some of you, how many of you are not familiar with cavitations? Okay, so we'll go over that. Not a cavity, but it's still a hole. So cavity is a hole, cavitation is another hole, but just deeper. So I'll go over that. And why is there a problem with cavitations? Dental implants, where are we with that? I myself have a dental implant, but we're moving more into ceramics. We've had some recent studies when it comes to autoimmunity and titanium. So now we're looking a little bit differently at dental implants. So I'm going to mention a couple articles about that. And also, mercury safe removal. What do we do it? How do we do it to keep our patients safe? And I would love your input in how you take the patient from there. And also biocompatible materials. We have some really amazing materials today that are filled with ceramic particles, even fillings that are BPA free, filled with ceramics. So not necessarily having to go to a crown. Like, what's the best way to restore? The old technique where you have to shave a whole tooth and basically destroy the whole tooth. We don't practice that way in biological dentistry. We're about conserving tooth structure. So in our practice, I'm very fortunate to have an amazing team of friends. And we have 3 restorative doctors who do biological dentistry and mercury safe removal. I'm the periodontist, and I do most of the surgeries. So removal of infected teeth, cavitations, dental implants, periodontal disease, laser periodontal treatment, which is non-surgical. And we have Dr. Magami. She's a prosthodontist, and she's a maxillofacial prosthodontist. So she actually treats cancer patients. She does prosthesis to occlude the palate. I mean, what she does is pretty amazing. It replaces eyes and all these things, yes. So biological dentistry, how is it different than just holistic? A lot of people ask that. Well, how are you different than a holistic dentist? we belong to an association called the IAOMT, and we go by what's scientifically based to be true. Sometimes holistic, has gotten a bad rep because we just, let's just try something that's, put honey on the tooth and see what happens. Non-evidence-based things. And I have patients that come and say, if I do this concoction and put it on my tooth, what's it gonna? It's gonna take away the infection. I don't know that because there's been no research to show that that's even gonna help. So we go more by, we have to have some kind of scientific basis for what we recommend. And we love technology in our office. So this is one of our operatories. We have a TV screen on each side. It's actually a 3D microscope that we work out of. We actually wear 3D glasses. And in the middle we have laser therapy. Both of the lasers are meant to not only reduce the gum, but we also use them to reduce the tooth. So it's a lot less traumatic. They create a lot less heat when we work around the tooth versus a traditional drill. And then of course we have a CT scan. This is our 3D microscope. I'm wearing the 3D glasses, but I'm not looking inside the mouth. I'm actually just looking at the screen. So I'm able to really magnify a tooth and see what's really happening. We see micro cracks. So it's really, dentistry is so much fun today. Yeah, because we have a lot of different tools. Except, my staff is like, oh no, here comes another gadget that we have to learn about. That's the only downside with that. And this is the little microscope actually that sits right in front of the patient's mouth. We also have a digital scanner on the left-hand side. So the old traditional technique to take impressions with goop. Now we use a 3D camera, which is a lot more accurate. So it gets rid also of some toxins because some of those materials are chemicals, but the 3D image is a 3D image. We don't use any kind of chemical materials to it. So a big principle with biological dentistry is this biocompatibility testing, because we know we're all individual. We have our own genetics and genetic expression. So we don't want to introduce a certain material that might be toxic to that patient, even though we choose in our office the safer materials that are out there, but they're still synthetics, right? When you're dealing with fillings and crowns, they're synthetic materials. So Clifford testing, are you familiar with Clifford biocompatibility? Clifford testing is a blood test that we do on our patients before undergoing major restorations to see what is compatible with their body. Like, is the filling compatible to their body? Is their cement? Is the implant compatible to their body? So it's a blood test. We usually get it back within 24 hours. And it's not 100%, but it's still a better guideline than just guessing, especially some of our patients that have autoimmune diseases, they're sick, they're allergic to everything. We need to know. For a healthy patient, probably won't make much difference. But for somebody who's already suffering and their immune system is on overdrive, it will matter. So, acupuncture meridian system. I'm sure some of you are familiar with this already. And this chart was first introduced to me by one of the chiropractors we work with. And I made a copy and put it in the operatories. And essentially, every tooth is related to an organ. Usually the molars are related to digestive, premolars to breast health. And as a matter of fact, we had a study that was published, not in our office, but it was published on PubMed, a few hundred women with breast cancer. They all had root canals in their teeth in the premolar area. So, and I'm going to share a case study with you that's related to that. So the thing is, root canals don't hurt. So you can have these underlying infections without even knowing that there's a problem. And that meridian, somewhere in that meridian, will suffer. Galvanic current, we actually have a little machine that we can measure people's galvanic current in the mouth. So if you're ever interested, you're welcome to come for a field trip to our office.
This is what Dr. Tennant talks about in his book. Have you read it?
Yes, I know Dr. Tennant very well. I've taken some of his classes. For those of you who don't know Jerry Tennant, he was an ophthalmologist, was bedridden for a couple years because of a tumor. He had chronic fatigue. Then he found out he had a bad chronic infection in one of his molars. that was root canaled. He had the tooth removed, then he started getting better. His tumor just went away.
From his surgeries, he was an ophthalmologist using laser, and he nailed virus, and he got encephalitis from 4 different viruses.
I don't know that story. He just talks about his tooth story all the time. So now he only practices, so that's how I know of it. It's fascinating. And he has a book called Healing is Voltage, so in which he relates all the electrical stimuli. And he talks about how disease actually has to exist only on a certain voltage. And I remember if it's positive or negative, but yeah, it's fascinating, his studies. So he's no longer an ophthalmologist. He hasn't been for years. He went completely into this direction. He became an acupuncturist, and now he just talks about how everything is related. And he has courses, and he has a microcurrent machine. We use microcurrent treatments in our office in order to help heal the area.
Is it T-E-N-A-T?
Tenant? T-E-N-A-N-T. Michelle, can you lower the blinds? Because Dr. Tanya's getting tanned on half of the face. So, yes, thank you. So I mentioned already oral galvanism, and really the only solution is to take out the metal. That's really, metal does not belong in the mouth. It doesn't. It did in the past because we didn't have better materials. But now we really have good ceramics, more biocompatible, that are metal-free. So this is what we typically see. You see a gold crown touching amalgam filling. And amalgam fillings typically are 50% mercury. That's the problem. So I grew up in Romania. I had 16 huge mercury fillings in my mouth. So I've gone through it. I had them all removed, unfortunately not safely. So I ended up with mercury toxicity, and it took me a couple of good years for me to chelate it out. So, I've gone through it, and it helps me explain it to patients, but I wish I knew then. Yes?
Sorry, tough question.
No.
Your last slide was about the oral galvanic testing of the metal.
Yes.
Now, are you able to, for a patient who thinks they may have a mercury filling still within, even though it's all showing as white, that there might be a remnant, will this show?
It will show on an x-ray. And we actually have patients that come in like that with mercury still stuck underneath the tooth. But if the tooth is vital, that mercury will travel.
I have to show you.
I'm happy to look at it. Okay. Good question. And we do see that on x-rays.
Excuse me, what about gold? I've heard gold is the best thing for the teeth.
So the question is, what about gold? Is gold the best thing for the teeth? Unfortunately, it's not pure gold. So if you look at my previous slide, this one, it can even have cadmium in it. And cadmium is a toxic metal. So we do recommend also removal of gold because we don't know what kind of other alloys. And patients don't know, and a lot of them are 20 years old. Who are they going to contact to find out what lab did it if they did it correctly? There is a lab in the Valley that actually does biocompatible gold inlays, onlays for patients, but nowadays we don't recommend really
There's a
gold
dentist
material
also
because of the ions.
It does that. I forget where he's at, but yeah.
He probably does that.
But
Yeah.
It's intense though to go in there. He tests you.
That's good.
You have to go in 3 visits for 1 tooth.
Yes, but most dentists don't do that. It's unfortunately we don't know what other alloys go in gold. It depends what they ask for. They can be mixed with different metals. Yeah. So electrical currents produced by amalgam can cause other problems in the mouth. For example, burning mouth syndrome or lichen planus. We actually do see the changes. And what's interesting is that we also see the microbes are different in areas where there's a current. For example, now we're doing studies with titanium dental implants and zirconia dental implants, completely different microflora around them. Because we think bacteria and pathogens actually communicate via electrical currents. So of course they would like an electrical current. As a matter of fact, they actually, when we look for cavitations in the jaw, they go straight for the nerve because they like to use our nerve system also as a way to communicate between colonies. They're a lot smarter than we gave them credit for. essentially. I think we just ignored them for the longest time. Even in periodontics, hi Dr. Moss. Even in periodontics, we used to treat everyone the same. You have periodontitis, okay, we do deep cleaning, then we do surgery, but then 3% of those people always got worse. Why? Because of the certain bacteria that was existing together with their genetic makeup. No matter what we did. So now what we're trying to do in periodontics is really change the flora. So we're basically wiping out the whole flora with ozone and laser, and then rebuilding it back with probiotics. That's where we're at, essentially. So, and I'm really seeing a huge difference when we treat patients that way. They're actually, you can download them. If you text 72000, I forgot to put that slide in, and text the word tooth, then you can download the slides on your phone. But you're welcome to take pictures too. So 72000, and the password is tooth. So if you dial 72000 and then you type tooth, it'll give you an option to download all the slides. 72000.
Okay, you're saying you're changing the flora.
Yes, we're changing the flora. I'm going to talk more about that. But we do see this. As soon as we remove the metals, we see an immediate change. Patients with metal restorations, essentially we see the following symptoms: Bell's palsy, tinnitus, vision disturbance, chronic headaches, trigeminal neuralgia, bruxism, severe depression, burning mouth syndrome. All these things can improve just by removing metals. So long-term influence of the most tested galvanic currents significantly decrease the cellular proliferation. That's really the problem. It doesn't allow healing. It really interferes with the normal cellular metabolism. And for those of you, if you haven't ordered dinner yet, we ordered. So, you ordered already? Okay, and we had, you guys are good. Okay, perfect. And it's informal, by the way, so feel free to ask questions. And we already introduced ourselves. And I would love to meet you.
Hi, Yasmin.
Sanda.
Pleasure.
What do you practice?
Acupuncture, stem cell therapy.
Acupuncture and stem cell, where?
Changing from Central City Medical Plaza to Ocean and 27.
To Ocean and 27. Okay, welcome. And then we have somebody new over here. A couple of you.
Oh,
hi.
How are you?
Good.
I'm Mona Lisa. I'm a dentist.
Oh, hi, Mona Lisa. General dentist? Anna Lisa.
Yeah. Close.
Mona Lisa. I'm like, oh, that sounds good. General dentist?
Yes.
Where?
In Maryland.
Very nice. Which street?
Camden.
Okay, you're a block over from us.
Yes.
From Roxbury. Okay, welcome. And then we...
I'm Jimmy Wu. I'm an acupuncturist and a teacher in your son campus college.
Oh, I work with Dr. Zai, Dr. Rina Zai.
Oh, really?
I've known her for
She's my
12
friend.
years.
She's my friend.
Oh, she is? Okay, yeah.
And,
I go to her for acupuncture. for 12 years plus, I think.
My practice is across from Empress College. I'm in the same complex.
Okay.
But my practice is in the garden, the 2001 South Barrington. But I teach it.
You teach it out.
Yes.
Come and say hello.
Oh, yeah.
Share it with me.
It's the second floor.
The second.
I'm out there all the time.
Come and say hello.
Great.
Great. And we have Dr. Moss.
Root canal dentist.
Fantastic. We're glad you're here because the root canal topic is coming up. We didn't want to have a dull moment around it. Okay. So, of course, the perfect way to eliminate electrogalvanism is really to remove the metals. Now, when it comes to titanium, which is also a metal, as long as it's sitting at the bone level and it's not exposed to the oral cavity, we don't see issues with it, when it comes to... But however, if the titanium is exposed in the mouth and they have another metal crown, it will create problems. So titanium implants are meant to be in the bone, not exposed. And then from the bone up, we do ceramic restorations. So let's talk about periodontal conditions and the oral... Sorry, I have to put the slide right when the salad arrives. Next time I have to plan it better. But I always look at tongues, and actually I learned from Dr. Zai.
Yeah, that means something.
Absolutely, yes. And she taught me a lot over the years, and I would always send her, actually, if I have a patient I don't know what's wrong with her tongue, I send her a text message. What do you think about this tongue? And she would tell me, oh, this is autoimmune issues. Yeah, this patient needs to get tested, yeah. So somebody like this, I really just look in the office for how is the microbiome, how is the digestion. So when I see a coated tongue that's whitish, that's dysbiosis. We know that. And if, the mouth is the opening of the GI tract. So I know that if the tongue looks like that, they can't have a healthy flora in the mouth. And the bottom, what's wrong with the bottom is a shiny, glossy tongue. That's also dysbiosis. It's not a healthy environment. What's healthy is this tongue on the right, where we see a nice pink tongue with no inflammation. If we see somebody with a shiny tongue, usually it could be even a nutritional deficiency, like an iron deficiency, for example. So next time, just check your tongue, see, check in. And also, we have tongue scrapers. Is like, and I have some patients that scrape their tongue away. But from a Chinese medicine perspective, your tongue's supposed to be healthy without cleaning it, right?
Yes.
Yes, right. And that's usually true. What's interesting about probiotics and the friendly bacteria for the mouth is that we know a lot more about it than we used to. And I've been really fascinated with the research in the oral microbiome. And the oral microbiome study starting about 2010. We have the oral microbiome research going on in San Diego. And a lot of the studies are coming out of there. And this is actually a study from 2011. A probiotic taken orally, like L-rhamnosus specifically, can even affect the stress levels just by taking one single bacteria. It lowers the cortisol level, which I think is pretty amazing. So how does that happen? We know bacteria talks to our genes, and it can turn genes on and off. Essentially, that's how that happens. So L-rhamnosus is actually one of the probiotics that's present in our chewable probiotic, Orasana, which I directly was involved in formulating. And it's a vegan probiotic, and we see big differences when our patients are using it. So this is what it looks like. It's a chewable probiotic. You let it dissolve in the mouth. And some of this bacteria, interestingly enough, and this has 5 different strains in it, it can kick off or ward off some bad pathogens. And they lodge themselves in. That's how that works. So they have research on this particular strains. They have not only an anti-inflammatory effect, they actually reduce IL-1, IL-8 in the serum. Anti-cavity, we have quite a few studies on cavities in children and adults, but mostly children that we're looking at. When they take a probiotic a day, it actually lowers the level of cavities. And also bad breath is another one, because bad breath is not just from the mouth. Right? It comes from the stomach, can be from sinuses, so it really affects the whole flora. So in this particular case, it's actually a case on peri-implant disease, which is an inflammatory disease. And what amazed me about this case is that, they had only taken it for 30 days, one chewable probiotic, and after 30 days, they measured not only the gingival fluid, but also the IL-1 and IL-8. Which really gives us the real picture, right? Because, the bleeding scores can be a little bit subjective. So it depends how hard you're probing. You can definitely get bleeding, right? So in this case, they showed lower IL-1 and IL-8 in both groups, both the healthy ones and the ones that had peri-implantitis, meaning inflammation around implants. Just by taking a bacteria, that's the only thing that in the study that they did. Polyphenols, it's another very interesting thing. So I want to bring up a product here that we love in our office. Curcumin, this is curcumin omega, an anti-inflammatory product. But what we know now is that the polyphenols in curcumin actually have an anti-inflammatory effect, but also an antibacterial effect. So when we're talking about the pathogens in the mouth, we actually also like this, let's see, do I have that one? Not yet. It's the curcumin gummies, which are sweetened with xylitol, with some xylitol.
These ones.
Those, and they're delicious after dinner treats.
Yes, we'll all be getting one.
Yes, They're quite addicting though, I have to warn you. But yes, it's a good way for patients to, instead of taking another supplement, it's more like a treat for them. And I like that this curcumin actually stays in the mouth a little bit for us. But periodontal diseases, that's how they manifest. So you as practitioners can definitely add, this. You probably, a lot of you are already looking in the mouth, but just, have them smile or just get a tongue blade and lift the lips. And if you see anything like this kind of inflammation, I mean, this lady actually ended up with leukemia. Because we know gums that look like this and they have spontaneous bleeding, that's one thing that's a sign of. So the mouth really shows us a lot of sign about overall health. On the right, we actually have, you see that darkness over the tooth on the right side, and on the left it has this nice white halo. The white halo is good, but on the left, that's actually bone loss. Okay, so that's what it looks like, inflammation. This is an abscess right here. That's an abscess over a tooth. It doesn't even show a lot of inflammation. It's just a white dot. And it's not cancer, though maybe it could be. But in her case, it was actually, I could put an instrument through that white pimple and, pus comes out. Essentially, that's what happens. And she has several implants. That's what the grayish look is here in the front. When we do a saliva test, and in our office, that's how I know what everybody's oral microbiome is. We look at 11 different periodontal pathogens. It's an easy test. When I was a resident, we used to do paper points because we cultured live bacteria. This was like, 18 years ago. And then we would send it to the lab. But the problem is by the time the live bacteria gets to the lab to grow it, it'll die. So we wasn't that accurate. So now we're doing PCR testing. We have the patient switch back and forth. We have them spit in a test tube. So we're looking at the dead bacteria that comes from the pocket. So around a tooth, there's a river. It's called the gingival clavicular fluid. When there's inflammation, that fluid spits out trash. That's the best way for me to describe it. That trash now we collect in a saliva test and we send it to the lab. This lady was actually in her 40s. She was a fitness model. And, she takes care of her body. She eats well. She eats right. But then all of a sudden she ends up at 40. When she came to see me, she had advanced periodontitis with a couple implants that were infected. And she's actually the one that I showed you earlier with the abscess in the front. So when I take an oral DNA test, this is probably the worst I've ever seen, when every single level of bacteria on her mouth was at extremely high levels. So when we look here, it's because high-risk pathogens on the left. What does that mean? In that group, those are the invasive groups. These guys travel. They travel to the heart, they travel to the joints, to the unborn baby, they travel to the brain, to the lungs. They're very invasive. And they, in very low amounts, they're pathogenic, meaning they cause disease. And she has high bars. Like, usually when we see no bars, we're happy. But she has high bars of everything. In the moderate risk group, there's actually one called Fusobacterium nucleatum. You might be familiar with Fusobacterium. It's been in the news lately, and I was asked to comment on it a couple times by different media sources. It's been linked to colon cancer and esophageal cancer. So in her case, high levels. It's the highest bar. And it's one that I commonly see with my patients who have a bad breath and bleeding gums. As the human oral microbiome research continues, and they're not even close to identifying all the microorganisms in the mouth, I know we're gonna, it's gonna change the way we practice now. So how do we treat somebody like this? Obviously she's infected. Ozone, exactly, that's a great one. But we also have to give her support for her body. Because if I just treated the mouth, or if I just started scaling and root planing a patient like this, which is what traditionally is done, it's the worst thing I could do for her. Because when you're scraping, all this bacteria goes straight in the bloodstream. It's probably already there, but at least now you're like... And we have studies from the VA, the poor VA, right? We did studies to show that after a dental cleaning, not scaling and root planing, there's a transient bacteremia in the blood. So every time your patient's going for a regular cleaning, they're going to have more bacteria in the blood. So in our practice, we always start with ozone, especially in patients with issues. We ozonate first to kill the biofilm, and then we clean. Because of this, we're just a little more careful about how we do things. Okay, so how do we treat somebody like that? We do ozone. So essentially, I have a cannula that actually bubbles ozone under the gum, and it reaches. I can reach as deep as 6-10 millimeters, depending how deep the pocket is. We might have to numb them at that point, depending how sensitive they are. But we can ozonate deeply, and we use ozone gas, but we can also use ozone water. And of course, ozone. I know you mentioned you use ozone already here, and probably a lot of you are already familiar with ozone. And then I also use a laser for periodontal diseases. This is a chromium YAG. And the nice thing about it allows me to curette the epithelium inside the pocket without having to raise a flap. So at a certain frequency, it has that ability. The other ability that it has is to bring osteoblasts, which are the bone-forming cells, from the bone up into the pocket to regenerate bone. And there's only 2 lasers on the market that are FDA approved for bone regeneration around teeth. So that's how we do things nowadays. In the past, how did we do it? Bone grafts. Just add a bone graft and hope it will take. But typically that's not the case. So we find much better success rates this way. Yes?
Sanda, have you ever ozonated from the blood itself and given them back the infusion before you do it?
I haven't done that. To actually take out blood?
Yeah, so we would draw at least 60 to 120 cc's of the patient's own blood.
Okay.
Just a little bit of heparin, infuse it into like a 250 cc saline bag, and then when we take the ozone, we mix 1-to-1. So we take out 60 cc's of ozone, inject it back into the bag. Now that blood is ozonated and it drips back through the body, so it ozonates
Oh, that's great.
from a systemic standpoint.
Yeah.
Not just a little
I wish.
bit.
Can we work together?
But if you have a
I-
machine, you can do that too.
No, I don't, because the ozone machine. Yeah, we're not. It's out of my scope of
Oh.
Yeah. But yeah, that's the benefit about
But you guys
working
are doing-
together.
Sorry, you guys are doing it in your practice as dentists? Ozone
No.
therapy?
MD.
MD, got it. You're doing ozone therapy as an MD.
Yeah.
It's legal in California.
Yeah.
There are states that is not legal in.
Yeah.
Oh, I didn't know that.
Ozone is considered very marginal.
Oh, yeah.
There's a guy, Dr. Rowan, I think, plus, I think he.
Is it a bad?
Yeah, he's in bad.
Yeah. Yeah. So we have the first FDA ozone water generator that was approved in California. Actually, it was designed by a dentist. It's called TheraZone. So that's an easy thing to implement, at least in the dental office, to just make ozonated water. Because that in itself, it's great.
In the area, is that what you're saying?
So when our hygienist cleans, he uses ozonated water, and we use ozonated water to clean the dental lines, because the dental lines can be really filthy unless we clean them. So there was a 60-minute report on how dirty the lines are at your dentist. So yeah. Oh, sorry. I'm sure it was fine. But yeah, it's important to check these things. So when we talk about gingival health, this is another product that I love, is CoQ10, and low levels of CoQ10 are actually linked to periodontal disease. Because it's actually found mostly in the heart and gingiva. So that's why also there's a correlation between periodontal disease and heart. We know that. There's an increased risk of cardiovascular disease with untreated gum disease. Yes?
There's also a risk of periodontal disease on patients with statins.
Yes.
I did not know that. There's a risk of peri disease. Oh, I knew about the hormonal issue, but I didn't know. Okay, thanks.
You always have to take CoQ10. Every country in the world knows.
Because it depletes that,
When
yes.
they do heart surgery, they actually, the back, the heart in it has CoQ10 in it.
Interesting, I didn't know. Okay. So we have studies to show that actually CoQ10 in conjunction with a deep cleaning, like scaling and replaning, it actually improves our results than if you just do scaling and replaning by ourselves. By itself without any kind of supplementation, especially this is a study on CoQ10. curcumin gummies, I mentioned this earlier. We use this also for people with, especially we have people that say, I don't want to take any pills. Okay, well, this is an alternative. And it also has xylitol in it, and xylitol has been shown to decrease periodontal pathogens and also cavities. So we like this product.
So you said the CoQ10, you use that before and after also?
Before and after. And usually have somebody, if somebody's prone to periodontal disease, because genetically they're prone to it, I would just have them stay on CoQ10 indefinitely.
And how much do you give them before you clean your teeth?
So we recommend, this is, I believe, the 200 milligrams, so you can take 3 of these before cleaning.
You mean these, or what
These
about
particular ones. So 600 milligrams of curcumin. It gives
and
you total.
also the CoQ10? With
Oh, you're
it?
talking about CoQ10, sorry.
Because you said you use
Yeah.
that before they clean the teeth,
So
right?
this particular one, and actually I put the omega D3 here, but it was meant to be the CoQ10 bottle. So the CoQ10 itself, you can give them, again, I would say 500 to 1,000 milligrams of CoQ10. And of course, vitamin D3, very important for periodontal health. We have, and cavities, it lowers the risk of cavities with optimum levels of D. And we know that we have less missing teeth with people that have a good, adequate D level. Any thoughts, or what are your thoughts about the optimum D level? 60 to 80, 60 to 100, okay. Okay, because I still have patients that come in, oh no, my doctor said I'm good at 50. But also we have a lot of patients who are vegan and, working in Los Angeles, I'm sure you do too. And algae omega, actually, is, and I love this product myself because sometimes I have nausea from fish, but this particular one is really amazing. We really have a lot of our patients who like the algae omega. It's not as much EPA DHA as in the fish one, but you can certainly get that. You just take more tablets. But what do we know? Some interesting facts about omega-3 fatty acids. P. gingivalis is one of those aggressive gum pathogens, periodontal pathogens. And these are animal studies, had less alveolar bone resorption if they had a diet with omega-3. So less bone loss around the teeth. Also, Fusobacterium, whom I mentioned earlier about being related to esophageal cancer, omega-3 fatty acids suppress this bacterium. We don't know the exact mechanism. We just see definitely that there's a reduction just by actually taking omega-3 fatty acids. Some dental implants. Okay. It looks painful? No, it's well, so this is somebody without upper teeth. Okay, and they might come to you and they might look with all teeth. So it's good to ask them, do you have any prosthesis in your mouth? This patient, when you look at him, he smiles, he talks, he has a full set of teeth, but when he takes them off, this is all you see. It's all metal, top and bottom. So, but he functions fine, he's 80 years old now. The only problem is the swelling of the gingiva, and again, probably some of the galvanic current, but also you can actually see the white of the palate. This is actually taking a view from the top, and that red all around the metal. So what's the issue here? He was wearing his dentures.
That's his palate?
Yes, that's the palate.
That's not a mandible?
No, this is the palate, and that's actually not a tongue. I know it looks like one, but it's the roof of the mouth.
It's a roof.
That's the roof of the mouth. It's like looking up at somebody, like, It's supposed to be that color, white. Everything else is bad color. Because he has a fungal infection in his mouth. So it's reddish. The tissues become red. When we hold, so with dentures, this is the problem with dentures or prostheses that are removable. They're plastic and they harbor bacteria, and they're porous a lot of times. And they harbor especially fungus. So if you're working on your patients, they have a yeast overgrowth, ask them if they have removable prosthesis, because that could be a lot of your problem. And then we look at the gums, and they look red and inflamed. This is a fungal issue. So how do we treat these people? We actually make a ozone tray, and we actually put it in the mouth. It looks like this. And through these tubes, we actually have ozone gas that floods the tissues. And 10 minutes for the top, 10 minutes for the bottom. And then we put them on probiotics, and we can really turn around. And we, of course, have to soak the dentures in ozone water. And that's the only way to really get rid of a fungal infection.
How many treatments do you think?
We do 3 treatments to begin with, and then we evaluate them. But once we make them the trays,
Every week or every day?
we do every week 1 treatment. And then we have them use the, sometimes we give them ozone oil to continue at home. There's an ozonated oil. I think we actually put on the gums.
Make it and you give it to them?
We don't make it because it does take 2 weeks to make. So we buy it.
You can buy ozonated oil.
Ozonated oil in little jars.
Who sells that?
Pure O3 is the one that we use, but there's a couple other brands. I don't know if you use any ozonated. Longevity has. Yes. That's a Canadian company. Yeah.
And they just rub it on?
They can rub it on. But then we have to be careful with ozone, okay? Because you don't want to wipe off all the flora without introducing some good ones, because they can get ulcerations just by having no flora. That's happened to me when I was experimenting on my own gums. You know, and it's like, let's see what this oil does. I literally sloughed off the gum because, and not by rubbing, it's because when you were killing good bacteria, we're gonna have issues. And I have patients that are so obsessed with getting their mouth sterile that they're endangering their own well-being. So it's about, you know, living in harmony as well with our microbiome.
How long do you do the tray treatments for?
10 minutes each charge. So after 10 minutes, we already see the color coming back, especially in the back there. I mean, we're already seeing oxygenation of the tissues right away.
And Sanda, what are you recommending that they actually put in their dental implant? You know,
The actual prosthesis, so we actually soak it for a good 30, 40 minutes.
in the office?
In the office.
What do they do at home? Just
Yeah, so yeah, good question. Since we can't give them ozonated water, their only chance is really to soak it. There is actually Dr. Berland, who's a dentist. He makes this really great soaking tablets that have been shown to kill fungus and bacteria, and they're not as toxic as some of the stuff that's on the market. It's more about.
Clinic acid, SF722 is
I don't even know what's what exactly. It's not acid. It's not hydrochloric
So
acid.
you would recommend people soak their dentures in this?
Yes,
Anybody?
anybody.
Where do you get that?
We have it at our office. I don't know where else is that.
Dr.
Carla
Berland?
can give you some information where else to buy it because I'm not sure if they. Dr. Berland, Berland.
Wouldn't peroxide help?
It could help, but I'm not familiar with the studies with peroxide and fungal killing.
I wouldn't put
Yeah.
peroxide in my mouth, no way.
No, but
It's
after
very
your
toxic.
dentures.
It's very toxic,
No, but there's like food grade.
Food grade peroxide. Yeah.
So what about if you have if you have a plastic or in your mouth or tooth, are you saying that is all even though you take it out at night? Is that still rebuild?
So the question is, if you just have one tooth, and just pay attention to the tissues. Like you can look, just take out the piece and look at the gum tissue, see what it is. If it's red, then it's a problem. If it's the same color as the other gums, then it's not an issue. Yeah, it is a very common problem though, to see fungus associated with dentures or removable type of prosthesis. So this is like an ozone water maker that we do make in the office. You see here the ozone is actually bubbling. I also, in the meantime, I have an ozone machine that just, you press the button and it gives you ozone water, which is amazing. That's my favorite one to use. Because obviously it takes some time to make ozone water, otherwise in a flask. This needs to bubble for about 20 minutes.
Do you have them swish and spit that?
Yes. It's a pre-surgical rinse, we use it in hygiene. We use it for a lot of different reasons.
You have them drink it as well?
Yep, we have them drink it.
That's pretty. What is that machine?
This is actually a cylinder, and we have just ozone bubbling inside of it. It's not the name for it. It just,
So it's just a switch. You
A
don't
special
drink-
effect.
You switch it, you don't drink it, right?
You can drink ozone.
Should you?
You can, yes. I mean, Dr. Collins might know more about it, huh?
But I mean, you wouldn't just drink a glass of ozone water to help, would you?
You can, yeah, absolutely. It oxygenates, and if you have, I do it. I drink ozone water, not all the time, once in a while. Enemas with ozone is amazing. It detoxifies the liver, definitely. Yeah.
Can you buy those machines to make ozone?
Okay, so you can buy
We drink it whenever we feel.
with the home generators. They're not as strong. But if you have a practitioner license, you can buy a more professional one because you need to purchase. We use medical oxygen. That becomes a limitation. But if you can get medical oxygen, then you can make ozone. You can buy an ozone generator and make it at home. Yes.
And who do you buy it through? What,
Longevity is a great one. We have a longevity machine, and we have a Pure. Is it Pure 03? I think they make a machine as well.
Industrial oxygen for the lay public is the same as medical oxygen. And you tell people if you
Really?
have an oxygen canister, and you tell them you want to get it for water purification, and it's industrial, you don't have to have a doctor's license to do it, and you can do it for water purification, but use it for yourself.
Oh, that's good information.
Yeah, that's what they do.
So industrial oxygen is the same as medical. I had no idea.
99%.
Okay.
According to longevity.
Oh, okay. Okay. Are you using ozone in your practice?
I use it personally. My brother has prostate cancer, and he's doing it for rectal insufflation.
Okay.
Because it is for the prostate cancer.
But it's used for the rectal and the vaginal and the oral, but not for the IV one, right?
I
The
don't do
industrial
IV.
oxygen.
Yes, actually, they use the same one for ozone IV, but it's the doctor actually uses it for.
And there's a Dr. Schallenberger has a book. He's got that book on ozone, so he talks about different applications. Because I don't do really major auto chemotherapy and all that, but and I have patients that have done it and they ended up with like no more veins.
now,
Type of thing. They have no more
what's
veins.
that doctor's name with the book?
Schallenberger.
Frank Schellenberg.
Yeah. So how does ozone work? For those of you who are maybe new to ozone, it's 3 atoms of oxygen. There's a weak bond between two oxygen molecules. And when that oxygen comes off, it has a negative charge. And that negative charge really pokes holes in all the membranes of pathogens because they don't have antioxidant capacity. But it's actually not toxic to human cells. So it's non-discriminatory between bacteria, parasites, fungus. It kills everything. That's the nice thing about it. But on the other end, it actually primes the immune system. And Dr. Bocci from Italy, he did a lot of studies on how ozone works to create a whole biological cascade to prime the immune system and activate it to help the healing. So it has this dual effect, which is very beneficial for periodontal diseases. So now that you got your dinner, we got to talk about some cavitations. Anyway, so when I went to school, I learned nothing about cavitations. And we used to ask, what's that hole in the bone? Oh, it's just a hole. It's got no importance whatsoever. And then I started going to conferences, biological dentistry. I heard the word cavitation. I had no idea what it was. And I actually spent some time with a couple of colleagues that have been doing cavitations for 10 plus years, and I really learned from them why is it important and how to do it properly. So now, we get together at our conferences and we discuss what's the best way to do it. And essentially, 3 things are essential for cavitations. Okay, we need to use ozone, laser, and PRF. People do it different ways. Not all cavitation doctors do the same thing. Some people don't have a laser, so they only do ozone. So they scrape, they ozonate, they close. Some people do PRF, platelet-rich fibrin, and I'm going to talk about that. Or, some people don't have ozone. They use hydrogen peroxide. So you're going to see a lot of different variety. But from what we know, this is like the best, most effective way. And this is actually Sarah's CT scan. And what does that look like in the jawbone? This is a cross section. So the only way to identify, or the best way, should I say, is CT scan. We need a CT scan to see cavitations properly. So this is a 3D CT scan of the jaws, and we have a machine in our office. I couldn't live without it. I think everyone should get a scan to identify, are the root canals infected? Do you have cavitations? Are sinus, what's going on? So in her case, she's 27 years old. She developed this condition, muscle atrophy, and nobody has any idea why it starts to happen. She started becoming weak in her legs. She now is using a wheelchair by the time she came to us. she's seeing a lot of different practitioners, also integrative. She said nobody can tell me. She has Ehlers-Danlos syndrome as well. And she's very frail at this time. So she came to us. We saw what I saw in the jawbone. So this is normal bone, these little specks. This is the nerve in the jawbone. This is the lower jawbone. Everything here, you see it's the same color as the outside. That's the cheek, and this is inside the bone. It's pretty much the same. So it's a big open hole. There's no bone in that jaw above the nerve. That's one of the largest cavitations I've seen.
What's the white outline?
So the white, the line that, so basically that's the cortical plate of the lower jaw. So when we look inside the jaw, you see the cortical plate. And the round thing is the inferior alveolar nerve. It's this thing that courses in the jaw, right here. So I need to know where that is. So we ended up doing her cavitations, and essentially when we go in, we actually use a special instrument we drop into a cave. There's no bone. Oftentimes there's stuff oozing from the jawbone, either yellowish. One time I actually saw black, like it was black material that was coming out from the jawbone. And every time we test these things, they're never sterile. So every single cavitation I do, I work with DNA Connections, because I feel they have a better panel, or at least that's the one that I found to be the best so far. I want to know what's in there so I could see, I don't know if there's another, maybe we can help the patient from a medical perspective, they're systemic. So in her case, this is what it looks like sideways, essentially for cavitation, same thing. We just look for holes in the bone. When we get reports back from DNA Connections, this is what I typically get. So on the left here, you see a list of bacteria. One of them, I think on the right side, we have amoebas. Is this one with amoebas? No, these don't have amoebas. But oftentimes we find single cell microorganisms. I mean, what is an amoeba doing inside the jawbone? We have no clue how it got there. Most likely, so these are area where wisdom teeth used to be, and they were removed, and we all know, oral surgeons, I think they have a contest sometimes on how fast they can remove a wisdom tooth and move to the next patient. So they leave open holes, or maybe they don't clean the air properly, so the bacteria gets trapped in the jawbone, and a lot of them are anaerobes. They don't need oxygen, they'll survive just fine. And then we get cavitations. Essentially, it's a colony of bacteria that lives in the jawbone, where it shouldn't be there. And I don't know if you're familiar, Dr. Bredesen is the director of Alzheimer's at UCLA. He wrote a book called The End of Alzheimer's, and he has a whole program that's integrative, in which he basically showed the reason why Alzheimer's happens is as a protective mechanisms against the biofilm that's growing in the brain. But the question is, how does the biofilm get in the brain? So we think it's from the mouth, right? Because once bacteria is trapped in the jaw, yes?
Yeah, they've shown, so I'm doing a study right now with Dr. Lachani and his Alzheimer's test, and his research shows that there's 7 times more oral pathogens in Alzheimer's brain.
Interesting.
And I think normal people probably should have that word as well. So
Exactly. That's very interesting. Thanks for sharing that. Yeah. So as we're getting this new information, we have to look at these cavitations more and more. Again, underlying infected teeth, dead teeth that people are just living with and that have underlying infection, they're not feeling it. That's why we need to check. Because bacteria travels, it doesn't stay in the mouth. That's the problem. So what do we do with this? Once I know this, I even had a virus. So they look for viruses, parasites, bacteria, fungus. They look at the whole spectrum. Sometimes I only see one thing or two things. Sometimes I see a whole list of organisms. And right now, we're just gathering this data. We don't know exactly what to do with this. Okay, we're cleaning it out. I know I get ozone laser, but is this bacteria and the rest of the pathogens in the body? Do we need to do further? We don't really know exactly. We don't have specific guidelines. We know we're cleaning things out. And the patient I was sharing with you earlier, she had her wisdom teeth removed, and she remembered actually having dry sockets in those areas. If you have patients that have dry sockets, usually they will have cavitations 99% of the time. I did her cavitations. Then, she comes to the office like 2-3 months later, we're checking on her. She's like, I'm starting to feel better. I have no explanation. I mean, all I did is decrease the burden of pathogens on her body. Now she's even walking without a wheelchair. She's using a walker, but she's feeling better. And nobody has any explanation for what happened, except all I did was cavitations on her. And we see patients like this, and there's just a correlation that we don't know exactly if certain microorganisms are more responsible for certain things or not. So I think it's an exciting time to figure things out.
You inserted the ozone into your cavitation. Is that what you said you did?
Yeah, so essentially this is the steps that I use for cavitation surgery. Piezo, it's actually an electrical, like it vibrates bone off essentially. I scrape bone. I biopsy, I ozone laser PRF. And for those of you who are not familiar with PRF, this is the PRF over here on the right. We actually draw blood, we spin it down in a centrifuge. And unlike PRP, which is liquid, PRF is solid. So I'm able to pick it up there, you see on the right-hand side, and I'm able to pack it and actually condense it in a site. And I like PRF better because it has immune cells in it, and it's solid, so I can actually manipulate it versus just the liquid in itself. Yes?
Does that help the bone grow back?
So PRF stays in place for about 2 weeks, and it basically is full with growth factors, so it helps with the healing, yes. Yeah, so it stimulates healing. It has vascular endothelial growth factor, it has FGF in it, so it has a lot of good growth factors to help stimulate. Yes?
Would it be beneficial in the cavitation to do your laser that stimulates the bone growth?
I do that. Yeah, that's the kind of laser I use. That's exactly right. Yes. So that's why we use it, to help stimulate the osteoblasts.
So do you have photos of pre and post cavitation treatments?
I don't have photos. I actually have on my YouTube channel at Dr. Sanda. I do have videos of cavitation surgery. And I have a patient who actually didn't mind to share his experience about how he felt before and after cavitation.
Okay, with that treatment?
With this treatment. I think I posted that video maybe a couple years ago. And the way we would check for results, let's say, to see if the bone filled in. So typically it takes 1.5 years, but typically patients feel better and all of a sudden, they're like, don't come back. Or they come back for a cleaning and we never scan them again. Nobody usually wants to get radiated again with another scan. That's the only way to really identify. So vitamin D3, again, we talked about it in K2, very, very important for bone regeneration. I will not do bone surgery on somebody that has low vitamin D. We're not going to see good healing.
What's the vitamin K2 do you recommend? Because in Japan, they use it for osteoporosis, like 360 micrograms a day, very high dose.
Oh, wow. Yeah, I usually just use it in a mixture. I never recommend it by itself.
Okay.
Yeah, D3, K2, so I don't know.
They rarely recommend it alone because they haven't established the levels.
In K2 is not?
So usually it's 100 to 200 micrograms. The dose
Of
is
K2?
700.
Okay. Collagen is another very interesting supplement that I've been using lately because of the studies that have been coming out about collagen. I thought it was good for osteoporosis. Actually, no, it came out as a beauty thing, right? For wrinkles. And now the studies are starting. So some of the things that I found is that it may support the activity of other antioxidant enzymes such as SOD, glutathione peroxidase. It also can improve the skin by the number and the diameter of the collagen. Definitely improves that, as well as elastin fibers, because what it does is stimulates the fibroblasts for producing more. That's how it works. Collagen peptides administered daily over 12 months improved bone mineral density. And if you're interested in this article, this is from fullscript.com. It's a very interesting article. It talks about even lowering diabetes and all kinds of things on collagen. So I do use it with my patients. I recommend for them to get it for healing post-surgical, whether it's cavitation or there's implants. As we age, unfortunately, our collagen production goes down.
So which brand do you use collagen?
Nordic Naturals, I like marine collagen. So from all the research that I've done, marine is best absorbed. I know there's cow collagen, there's porcine, there's chicken, but marine has the best absorption.
Yeah, I found like a patient uses that's very hard to digest because lots of bloating and some people have constipation.
The marine one?
Like, no, like I don't know what's the brand. That's why I try to find
Proteins.
something like indigestion.
Yes.
Oh.
Vital proteins is very popular right now. They're very in right now. But the problem is a lot of those bovine and porcine collagens, the molecule is actually very large, and that's why your patient would be finding it difficult to digest. We specifically work with marine collagen because the peptide size is much smaller and we hydrolyze the peptide. In the studies that we did before we even formulated this product, because we're so particular about our products and what we put out there, we found that using marine collagen, the smaller hydrolyzed peptides is what actually got deeply into the gut and did its job to stimulate collagen production. So people who were having digestive discomfort with the typical products out there in the market today typically do much better with the marine collagen. It actually comes from the skin of our Norwegian cod that we catch for our fish oil. So we're repurposing the skin and putting it into this product, which is great. And I have a sample of it, but it doesn't smell fishy at all.
I actually put it in my coffee.
Yeah, doctor puts in her coffee every morning.
Yeah, so I put it in the coffee. It has a little strawberry flavor, but I like it in the coffee. It's like it's a powder. What's that? Does it come in chocolate? I don't think it does. There's only strawberry flavor. It should come in chocolate.
We really should, yeah.
I put chocolate collagen in my coffee every morning.
And you know, chocolate coffee. That's great. Collagen chocolate coffee. Very nice. And it dissolves very easily. That's another nice thing that I like about it.
So how many flavors should it have?
Only one.
Strawberry?
Why did you pick strawberry flavor? Yeah.
It'd be interesting to inject that into the tissue around an implant to get it to hold tighter.
To inject collagen?
Yeah.
Yeah, I don't know what even forms of injectable collagens are out there. The kind of skin collagen, I guess, for beauty? Or, I don't know, but it'll be interesting, yeah. We don't have any studies on that at all. We don't do it injectable collagen.
Why?
One has to digest it.
Right.
Can digest it.
Right.
What do you think? Maybe a proline, injectable proline? Because proline causes hydroxylation. But I've never done it.
Okay, so root canals topics, very hot topic. I have so many patients. Have you guys seen root cause?
They took it
Yeah, so many patients that I've called.
Yeah.
After that, they took it off because I think the ADA went up in arms about it. I had a lot of patients that called. I want my root canals out. I'm like, oh, wait a second. Let's scan them and see what's going on. But what are root canals exactly? Okay, we take out the nerve. We want to prolong the life of the tooth, the life, so to speak, the presence of the tooth in the mouth. Without the pain. So the only way to get rid of the pain when somebody's in pain is to remove the nerve. So we remove the nerve. Well, Dr. Maz, I don't do that. He does. But we remove the nerve. So instead, so for example, this is a healthy tooth right here. You see that dark line? And next door there's a white line. So that's filled with a material. It could be different things. The traditional thing is actually cork from a tree called gutta percha. That's true. I think, but endodontics is going through a little bit of a, renewal. Because now we have better materials, and you could probably talk more about this. Bioceramics, right? To help with the sealing. But the bigger problem is the bacteria that we cannot clean from the tooth. So there's better techniques now. I was mentioning to you earlier. So this is the canal. This is what it looks like inside the tooth. And these are courtesy of Dr. Valerie Cantor. She gave me these photos, and this is where the nerve used to be, and now it's just a hole. So it needs to be filled with something. We can't just leave it, all bacteria gets in. But the problem with the gutta percha or with a rubber, as you know, just like a wine bottle which has a cork, this winemaker told me after 10 years they have to replace the cork. I'm like, oh, that's interesting. That makes sense why root canals, usually after 10 years, we got to replace that cork. Because usually when we enter it, and I've seen them through the microscope, the gutta percha is surrounded by colonies of bacteria, even though it has no lesions on the x-ray. So, but it does smell. If you ever open up a root canal that has a little, it gases off. So, we have to take a CT scan in our office. Like, we can't work without it to see where exactly the lesion is. A canal that's not filled, perhaps. If you actually look at an x-ray, this is an x-ray, regular x-ray. You don't see anything above this tooth with a white line. On the right, huge infection. The dark thing is an infection. Regular x-ray, CT scan. That's the big difference.
Big difference.
We cannot. I think every single root canal tooth should be 3D scanned. Every single one.
I would agree.
Thank you. Yeah, you were in agreement. Yeah, it's very important. We can't see anything. So, we looked, the studies actually showed that we're only able to diagnose about 55% of the problems using irregular x-rays. That's pretty low. 55% to diagnose. So we have better technology today, so a lot of us are getting on board with this. So we do know that oftentimes when a tooth is cleaned, the person who cleans it misses canals, and bacteria is stagnant inside the canal, and that's why it fails. That's why the bacteria goes inside the bone and we get an infection. So here you see the white dots, those are filled canals. Where you see the black dot, it's a missed canal that needs to be filled. You see the dark there? That's what it looks like inside the tooth. Instead of being white, we see dark. And the orange material, that's actually the cork that I was telling you about. So I know some people that are doing nowadays are not doing any more gutta percha at all. Are you still using gutta percha, or are you moving more towards bioceramic? Gutta percha still. And you know what's interesting? The biocompatibility testing, most people don't show that they're compatible with gutta percha.
Which test are you doing?
Clifford.
Okay.
So that it causes some kind of, reactivity. Yes.
Is it when it's extruded through the brain or just?
So the Clifford is a blood test. So we don't know. So basically, they take the gutta percha and they put it. They do the testing, and Mr. Clifford who owns the lab. I mean, he's very friendly and everything. So basically, if he sees a reaction, like an immune reaction to gutta percha, he says not suitable for that patient. And most gutta percha is not suitable. Yeah, you should. I can give you his contact and see what that's about. So that's why we're moving more towards bioceramics. Clifford. So it's called Clifford Labs. Yeah, and he's been around for a while, maybe 20 years. Yes, and he's got a list of 700 different materials for biocompatibility. So this is from actually endodontics, root canal implants and disinfectants, which they actually found that current solutions and techniques fail to completely remove all irritants, dissolve all tissue, and remove the smear layer. That's the problem. So we need to get better at cleaning inside the tooth.
I have a question about
Yes.
about Clifford Lab. If you have it done, is it good indefinitely, or do you have to have it redone?
He says it's not good indefinitely because our bodies change, and depending on what we're exposed to, we'll need to redo it. Let's say if it's 2 years old, we'll need a new test.
Okay.
He doesn't have exact guidelines.
How old test I had it.
Yeah, then if it's
okay.
probably need to redo it.
Okay.
So this is the issue. This is looking inside a tooth, going up towards the top of the tooth. See, the dark holes are the holes inside the tooth. Now the tooth splits. So all these little things need to be filled properly and cleaned properly. That's really the limitation. Look at all the little tiny little holes where bacteria could be. Okay? And it's still going. All the way to the top of the tooth. Many little crevices. That becomes very difficult to clean.
Animation.
Thank you. Yes. The doctor from Brazil shared that with us.
What
So
was his name again? Dr. What was his name?
where?
And from Brazil. What was his name?
Ordinola. So this is the association between chronic apical problems with the root canals and coronary artery disease. It shows that there's 3 times more likely to develop cardiovascular issues with the uncleaned root canals. So what kind of things are inside the canal? again, we don't really know which ones are worse than others specifically, but they found endodontic bacteria in almost 80% of thrombi, and then periodontal pathogens in about 35% of thrombi. So we know they travel. So we're just, I think, now at a good time to figure out exactly how we can, more effectively keep a balance between positive bacteria and pathogens. Questions about that? Root canals. So there's studies being done essentially how to clean these better with lasers. I think there's a new machine, the one that I don't know. Okay. What's your experience with that?
I actually ended up purchasing one about 8 months ago.
Okay.
With that anatomy, the little slide.
Uh-huh.
So a lot of those surfaces we don't touch. So typically when you do root canal therapy, you have rotary files. You put in an instrument and it just rotates and you go in and out of canals to remove the infected nerve. But a lot of times they have little deltas, little intricacies, or little pockets where curves of the nickel titanium can get around, but there are little deltas, there are little anatomical areas where no matter what instrument you use, you're never going to get into. So there's a machine where, imagine once a tooth is, you make a hole to start the root canal therapy, then the handpiece goes over it, it creates a suction, and it spits out solution, typical solutions that we use for root canal therapy, and it kind of flushes the tooth out. So by the time you finish your root canal, you kind of see sealer going through all the little areas where you would normally typically never touch.
So it puts the sealer in as well?
No, it only just cleans it out. When you initially go up to fill the canals, when you take an X-ray, you see this little cool anatomy inside. It flushes it out. We don't fill the space with gutta-percha or with plastic filling material, but you do see the sealer. And really in endodontics, it's the sealer that seals the root canal therapy. It's not the gutta-percha. Gutta-percha is just like a fluid, like a paste almost. Oh, there's different types. There's one with calcium hydroxide, there's other stuff. Depending on what condition of the nerve is, when you finish your root canal, depends what you use. Some are more toxic and can cause some typical periodontitis, sensitivity when you touch the tooth. So you use calcium hydroxide if it's like a normal tooth or just an infected nerve where the bacteria is not into the bone.
Yeah, so I think we do have better materials now, but the question is, which anatomy can we clean best? Obviously the ones with single roots, much easier than molars. Molars are so intricate. In terms of, I was showing you a molar earlier, but single rooted teeth are a lot easier to treat. Yes?
Yeah, the research that I've done, I read Dr. Mining's book, Dr. George Mining's book, who uncovered Dr. Weston's Price's work, and he said that no root canal is good. And I'm not sure if I'm getting this right, but the tubules in a tooth, that they are miles long, and no matter how well we clean them, we can never, because it's always exposed. So bacteria is always going to get there. So Dr. Price, who invented endodontics, who invented root canals, said after he did it that he knew that he'd done wrong, and he was trying to undo it, and it had already gone on too long into the system. So that book, Root Canal No More, I read that book a long time ago, and the biological dentist that told me that root canals weren't good. You just had to pull the tooth.
What you're saying is absolutely true. Even with a successful root canal, you're never really removing all the bacteria. All the bacteria inside the root canal system. So imagine if you have a front tooth with one nerve. The nerve will go up. As it's going up, what she's referring to, tubules is little tubes that kind of go towards the cementum or the dentin. And bacteria can harbor in those little tubules. The only way we typically have cleaned those canals is just with bleach to clean out, remember household bleach, to clean out the bacteria, and then we filled it. And then with the cement kind of goes into the little tubules and kind of fills them up. But are the tubules getting completely flushed out from where the nerve is to the cementum? Absolutely not. I don't think there'll ever be a machine that will ever do that. But go ahead.
But I have a question. So when you clean it out, though, ultimately their symptoms and their pain goes away. So the bacteria is significantly reduced, right?
Sure.
Where there's, yeah, well, no, even if the nerve is taken out, your tooth can get reinfected, right? So if like, because they can get reinfected like 20%. So I think it's like lowered to a certain point, right? Where they're not in.
Knock on wood, there's a reason I'm in business. So root canal therapy or any general dentist that does root canal therapy, the success rates are pretty high. They're saying between 92 to 98%, much like implants. When a tooth goes bad, guess what? We refer to a doctor like our doctor here because they just take a tooth, happy to do it for an implant, and then it's good as new.
What are we really looking at? We're looking at the children, like the candy, world, the kisses and all the candies that we feed our children. One woman that I know, she was about 90, and I asked her, "Do you still have all your teeth?" And she said, "Yes, I do." And I said, "Well, how did you eat when you were a child?" She said, "My father grew all our food. My father, they ate very clean." So in the modern world that we have, we've created all this in our environment, and it's rotting our teeth, all this sugar. So I look at it as like it's just really important that we educate and teach the children.
I said I was reading desserts. You're telling us about how we're rotting our teeth. No, it's okay. It's
I
okay.
can't eat sugar anymore because I've had issues. Because when I was a kid, I had a lot of sugar.
Yeah,
and
me
so
too.
I can't eat it anymore. I can either eat it or else I have to.
But no, there's some sprouts in the middle.
So I look at it, but I mean, I'm grateful that I don't have to go, anyway.
And I'm with you. I grew up with sugar. That's how I ended up with all
Me
that
too.
those
Me too.
fillings. And I already have an implant. So, and it is traumatic. I have patients that come in the door with 12 root canal teeth. What are we going to tell them? Take out all your root canals? It's very traumatic for a person to lose their teeth. Yes.
I have a question.
Yes.
Lots of time people also say if there's a tooth and health, also there's quite a lot of percentage related to the genetic. Is that right?
Absolutely. The way we respond to things, it's also, has a genetic predisposition. Yeah.
I mean, gum is important in health. It's really important.
And speaking of how we respond to things, I'm going to talk about the autoimmunity issues with titanium implants, right? Because now we're saying, we're doing implants, but what kind of implants? Because they're not all. Yes. Yes. I myself have a titanium implant in my mouth. I wouldn't remove it. I wouldn't go ahead and remove it. I'm doing fine with it. But I have a handful of patients that have had titanium, one of my cousin included. She said, just take them out. I feel them. I don't like them. Yeah. Even though the blood test, the Clifford actually showed that she was okay. But I think some people just, I don't know. Is it clinically relevant? What is it doing now? We don't know yet. We don't know. What are the titanium particles doing in the lymph nodes? And is it a problem? Is it clinically relevant? We really don't know yet. So we've had titanium dental implants since 1970s. 50 years, a long time. Millions and millions of implants have been placed. And a lot of them have stayed in the mouth for 30, 40 years. We have titanium hips. We have titanium knees. We also make zirconia hips and knees. But again, some of the things we don't really know who's a candidate and who's not. So the way Dr. Von Baer explained it is really an unspecific reaction. And he links it to a polymorphism, which is the genetics, of IL-1A, IL-1B, and IL-1RN. If you have a polymorphism and all these three, basically he said you're going to see periimplantitis. Guaranteed. So periimplantitis, meaning bone loss and inflammation around implant. It's like a foreign body reaction. People who have these three polymorphisms have an exacerbated foreign body reaction. So he says that it's impossible to be allergic to titanium because the particle itself is very small. So when the particle is very small, you cannot trigger a specific reaction, but you can trigger the macrophages for a non-specific reaction. So that's what we're seeing. People with this polymorph, but we're not testing for this. We're not there. So, but I have had there is a test for it, yes. Genetic testing, but I don't, environmental MDs do it. I mean, I don't really do it. The only thing I could test is IL-1, which is linked to also periodontal disease, but it doesn't break it down into these three components. Yes, but there's also titanium dioxide, from food, right? They add that, so.
In milk.
And milk, I didn't know it was in milk.
And have you read the studies of Dr. Smith about how Roundup, the herbicide they spray on everything, stops the detoxing of heavy metals from our brain? It actually picks up aluminum from your gut, puts it in your cranial gland.
Oh my gosh.
Stops you from being able to detox heavy metals.
I didn't know that. Wow. Well, we all have Roundup. I don't think there's one person on this planet that doesn't have Roundup. Yeah.
By the way, Coach Danny will not do glyphosate.
Oh,
They will not do a test for that.
really?
No, well, he knows better.
But the good thing is we're winning. There was a couple that actually won.
3 billion.
That's amazing. I'm glad that we're finally seeing that they're winning against Monsanto.
The EPA won't even check for glyphosate in water supplies in the United States. My brother used to work as a geologist for 8 years.
So does the filters take out glyphosate? It does. So we all have to have filters. Yeah, that's really it.
Their stock is down 40%.
Yes.
All right. I don't.
But that's why they're.
Why would anyone buy that?
So now we're at ceramic implants. So what do we know from the literature? Actually, it has lower plaque. Less plaque accumulates around ceramic implants, zirconia, than it does around teeth or implants.
Repeat that again.
Less plaque adhesion around ceramic implants, than other areas like teeth or titanium. It's just we see healthier tissues, less inflammation around zirconia. And that goes not just with titanium, not with the ceramic, but also crowns. There are zirconia crowns. The gingival tissues look beautiful. Yeah. Because we make zirconia crowns, we make ceramic dental implants out of zirconia.
So is that in relationship to the jewelry zirconia?
No, it's not. Let me see. Do I have
Can you make a
slide?
zirconia partial?
I think I have a slide somewhere coming up. Can you make a zirconia partial? You can make a prosthesis, which is supported on implants, which is like a horseshoe, but not one that will just rest on your gums. It needs to have implant support. Yes, we can.
But not without it.
Not without implants, because probably it's rocking, so you'll break it. And it's moving around too much. It has to be supported by implants. I've never seen one without implants.
What is the material zirconia?
So zirconium dioxide, that's what it is. And do I have a slide? I think I have a slide in here. I wanted to show you some cases. I have a slide coming up and I'll show you exactly what the zirconium. Zirconium is a metal, essentially. So let's go back here. But the other thing that we're seeing is better vascularity around mucosa when it comes to the ceramic dental implants. So it's clearly a biocompatible material. Usually we see constriction of blood vessels around, let's say, chronic infections or materials that are not biocompatible. But in this case, we actually see good vascularity. I wanted to share a case with you. 2 endodontically treated teeth that actually were getting resorbed. So the body does something very interesting. When it doesn't want something, it starts eating it up. Okay? It's saying, okay, I'm done with this. Okay? That's what's happening with this lady, her 2 front teeth. So these right here, if you see, they're kind of severed. They're chopped off. The neighboring teeth still look nice and long, but the 2 front teeth are resorbed. And she developed a cyst, the darkness around both of those roots, or a cyst. So of course they're loose at this point because of not much, but the only option is to remove them. And of course she's terrified You know, it's 2 front teeth. It's psychologically, it's very difficult. So she just didn't even want to be awake for this procedure. And I do want to show you this this procedure, how we do things. I hope you're okay with a little. It's after dinner, so so essentially, you know, we measure everything, and then the way I want to see where the bone is. Essentially, that's why I remove it, and then once the teeth are removed, this is called a piezo machine, in which we clean the actual cyst from inside the jawbone. And you're actually going to see it probably coming out in a little bit. There's ozone water that actually goes through the machine in order to clean, and it vibrates, and essentially that's a cyst that's coming out of the bone, and it's got this like yellowish white appearance. And I'm going to post this on my YouTube channel if you guys ever want to watch it again. Yeah.
Do you ever put colloidal silver in there?
I haven't.
Oh my
No.
God.
So I have to, the thing is she has holes going right through the buccal plate. So you're going to see it when I open this up, there's a hole there. There's no bone. So we actually have to raise the gums for me to be able to clean this properly. So you can see the water coming out right through that hole where there's no bone. You can see there's bone on the side, but that's what infections do. They eat up the bone.
That was the cyst.
That was the cyst.
So how do you get the bone back?
A good question. So in her case, I'm actually harvesting her bone. So you can see the implants here. So as I'm drilling, I'm harvesting her own bone with a special suction from her. Huh? From right when I was drilling. So as I was drilling, I'm collecting the bone chips in a suction, in a white suction. And then this is PRF that we put in the side to reconstruct the buccal plate. And the white in here are already the implants that went in. So then we put stitches there on the side, and then this is, I'm packing a little bit more bone here. This is her native bone that actually came out from the suction.
That's cancellous bone?
It's cancellous, yes, because it's just drilling from inside. So that's what the white implants look like. Then we actually put temporaries the same day. And we're going to make her some teeth, so she's actually leaving with something. So when she woke up, she had teeth. And that's where we're at today. You know, we can actually do these kind of treatments for patients. And she's going to have a temporary here. And then on the right is her temporary, and that's her healing about a month after the procedure. Yes?
Can I pause? You're going through this so fast.
Sorry.
People that don't see this all day long, that right there is the most difficult procedure a gum surgeon can ever do. It's such a difficult area to address. So that is phenomenal.
Oh, thank you very much. Thank you for that. Thank you.
You just went through like this, like it's
Like it's nothing.
Like it's nothing, yeah. Yeah. Sorry, okay.
that is very difficult to do.
You said those were temporary teeth?
That's what I love to do. You know, it's really surgery.
Those are temporary front teeth?
Those are temporary front teeth. And she's gonna, this is how she started on the left, and that's her temporary on the right. And we're just waiting for the healing. The implants need integration time. And those bone particles are all gonna fuse together, and in 6 months she can have final crowns. But essentially the goal is nobody should be able to tell that you have implants in your front teeth, right? That's the goal. So that's what they look like inside instead of those teeth. So we can see the bone is filled in nicely on the side. There's no gaps. But I wanted to share this article with you. It's delayed type hypersensitivity to metals and connective tissue disease and fibromyalgia. So they are mentioning titanium as an issue in exacerbation of these conditions. So now, and this is not the only article out there of this sort. So whoever has this, there's not, titanium is not even an option. Yes?
And actually, there's 5 causes of fibromyalgia.
Okay.
Fibromyalgia is a fake. It doesn't exist. No. These are the 5 causes.
Okay.
Number 1, fluoroquinolone antibiotics. Top number 1 cause, 80% of people with fibromyalgia have taken either Cipro or Levaquin at one point in their life.
Wow.
Yes. Second is going to be breast implant illness. That's why the majority of women have it, the silicone leaks. There is a tooth issues, either root canal or some type of, as you said, a hypersensitivity to a metal. And then you have things like mold and light disease. But that's pretty much, that rounds up the top 5 for it.
Breast implants would cause fibromyalgia.
Yes, breast implant illness is huge.
Interesting.
And it causes fibromyalgia. Yeah, they take them out, they're good. For the top five.
We have a few of our patients taking out their breast implants, and they feel much better. Yeah, yeah, interesting.
Because you get a micro condensate. It was irrelevant to this topic, but you get this. If you get the implant, you take it out, you push your fingers together, they'll stick. So it's a condensation happening, like a water cup having condensation through the glass. It's not leaking, but there's condensation.
And I've been told that there's a suspicion of mold actually growing in there after they've been in for too long. Somebody I know is getting them out because they have my mold and they think it's coming from the breast implant.
Are any surgeons actually testing that capsular tissue?
There's a great article on breast implants.
Okay. About the microorganisms, or just in general about
The autoimmunity.
autoimmunity? Yeah. So that's the story. So nowadays, that's a recommendation with ceramics. So more and more implant companies are actually coming out with a ceramic implant. But what's some of the challenges with the titanium? When we get recession, you can actually see the titanium in these cases. So we actually have to treat that, and it looks inflamed at that point. And it's not peri-implantitis. It's not easy to treat. It's very hard to bring back the bone around the titanium implant. It's unpredictable. The bacteria, once it enters into the micropores of the titanium implant, we can't get it out. Same thing. We don't have good methods to clean the implant. So we basically have to remove the implants and kind of start all over again. So that's somebody with titanium, with the ceramic implants. So they're really, really white. So that's what ceramics look like. Again, somebody with ceramic dental implants, 4 anterior teeth. So when we're done, even if you get a little bit of recession, this patient's starting to get some recession, you see a little white there, and the tissue doesn't look great. With titanium, we tend to look more grayish.
So do you see less of an occurrence of peri-implantitis with ceramic?
Yeah, and all the studies point that way. Less. This is a patient that had, we removed the Pontic. She was part of our study, actually, when I was involved with Noble Biocare. This is a Noble Biocare ceramic implant, and I'm one of their lead educators. And she had a bridge here. We cut that off. And the middle here now is a ceramic implant, and look at the neighboring teeth. The ceramic implant looks better, and the reason why the front one is turning dark, it's a root canal treated tooth. You can see on the right, but even the back one has a metal crown on it, so the gum receded away from it. Gums don't really like metal, especially the kind of metal, when you see a corroded metal, and the edges of our crowns are metal, but they're probably a base metal. So it corrodes easier. That's why you see the dark lining around it. So you see gum recession typically around that. Zirconium is a metal. So I have this conversation often, and I get this asked all the time. No, it's a metal, and it actually looks like that. We make screws out of it too. But zirconium dioxide, it's the ceramic. So once it's turned into zirconium oxide, it's white, it's a powder, and then we compress it into cylinders in order to make implants. We cannot, so there's no more metal particles here because we cannot turn it back into a metal. Once it's a ceramic, it doesn't have any of the properties of a metal. So it doesn't conduct electricity, it has no ion release. That's why we call it a ceramic. Okay,
It still doesn't have a matrix inside.
It has a matrix of crystals. The way the crystals are oriented, definitely it's a very organized pattern. And the way they figured out, because the problem with the ceramic implants, they didn't have enough strength. So now they figured out they're adding yttrium to it to strengthen it and to help align the crystals in such a way where it gives it more strength. So we're not having the breakage issues that we used to. Yeah. So Pauline came in. Paula, she had number 12 root canal treated tooth. She was diagnosed with breast cancer 4 months prior to me seeing her. She's in her 70, and she's like, I can't believe I have this. Why do I have this? Amongst other things, she said, my tooth has been hurting for 1.5 years. Which tooth is it? Oh, it's a premolar. She went to somebody in the valley and who's an orofacial pain specialist that she was referred to. He made her an appliance in the hopes that by getting the pressure off the root canal tooth, the pain would improve. It did absolutely nothing, and the pain would radiate all the way to the top of the head. And she went to endodontist, and nobody could see any cracks in the tooth. And I looked at her CT scan. There was a little bit of inflammation on the top, very little, easy to miss. And she explained to me the pain, and I told her, with your breast cancer diagnosis, it's on the same meridian, the breast. Take this tooth out. And she first was like, how come 3 other specialists before you didn't tell me this? She didn't trust me at first. I'm like, you have to take this tooth out. So that's what we ended up doing. We removed the tooth. Her pain went away 3 days later.
And breast cancer?
She's still, this just happened earlier this year, so she's still working through it. But I believe it's really part of her therapy by removing a tooth. And the tooth was cracked. It was actually a microfracture inside. That's why I usually have symptoms when we have a microfracture.
Is that the same laterality as the breast cancer?
Yes, same side. Same side. I mean, I can't tell you for sure, like what started when, you know? But we know there's a correlation. What's that?
I said the tooth.
The tooth started first. She's had that root canal for like 40 years, she said. But it cracked. That's root canal teeth are more prone to fracture. So that's why she was having those symptoms. So that's the one right there. We actually ended up replacing it. So I don't think I have time to show you another video, but this is very easy. I actually just ended up placing the implant after the tooth was removed. And the reason why I didn't do it immediate is because I wanted to make sure her pain went away. When somebody's coming to me in pain, especially radiating to the head, I won't place an implant right away. Okay, we need to wait. Pain is gone, then we place an implant. So in this case, no flap was pretty easy procedures, very standard for us to place an implant, do a tooth right away, no stitches. I mean, that's what we're really at today. Minimally invasive, not to do a major surgery if we don't have to. We make a hole, we place the screw. So, and then we actually measure the cord. She does, and I told her, next step is to remove all your metals. Absolutely. She needs to go, but she's. And then what do we do when somebody's diagnosed with cancer? She's working through her treatment. They recommended radiation and chemo for her. So
be careful about removal of amalgams during that time. And
exactly, we have to be careful to remove amalgams. So I always
I was
wait.
told by these doctors just one every 6 months. Otherwise, it's just so traumatic to the body. But we do it anyway.
Yeah, that's true. So, yes.
Do zirconium implants have the same structure as a titanium implant?
The same structure. So they have
As
this.
in one piece and you screw it on and then you put the crown?
Good question. These are what is called screw retained implants, which I like. So then I can remove the crown myself whenever I want to, because it has actually a carbon fiber screw. The older ceramic implants you can only cement the crown. They're one piece. There's a few problems with that. If anything happens, you have to remove the crown and start all over again. So I prefer a screw retained system, for sure. For sure, those are better because also cement can cause inflammation, and then there's some bacteria. There's not a fully sealed gap, so it's a lot more precise to do screw retention. Okay, so before we close the night here, let's 8:22. We're having a really good discussion. I don't know where time went, but I do want to mention a little bit about mercury before we leave, and the importance to remove it safely. And I shared, I think in the beginning, how I had it removed unsafely, and I ended up with toxicity. But anytime you have teeth grinding, chewing, even brushing your teeth, there's mercury vapors coming off the fillings. And this has been shown. And there was a sheep study that was done initially. Unfortunately, the sheep got silver fillings. A month later, they sacrificed the sheep. They looked at their brain, kidney, liver, lung, all mercury filled within a month.
Even saliva, that's it.
Mm-hmm. So that's the real issue. And unfortunately, in this country, we still have mercury fillings being placed. They've been banned in many countries. IOMT is suing, actually, the FDA first of all, and the ADA. We're in the process of a lawsuit for the last few years because there's so much evidence that mercury is toxic. And this is just a list of everything that it can involve: Parkinson's disease, Alzheimer's, we have autoimmune disorders, all kinds of different things. But IOMT, we have certain guidelines in order to remove mercury safely. And I think I have a picture. This is actually the removal. We have a high suction. We use a rubber dam. And when you see these kind of fillings, this is not exactly corroded, but the ones that are starting to look black, those are corroded. And the other problem with mercury is that it expands and it starts cracking the tooth. And that's happened to me. That's how I ended up with an implant. It cracked the tooth. And it takes years for that to happen, but the larger the filling, the more likelihood that it's going to crack the tooth. And you can see here some of the cracks already starting to happen around this filling. But on the right, we have Dr. Tevan and one of our assistants. They're wearing the masks for mercury removal. They have the patient has oxygen, and we have the latex, the non-latex barrier around the tooth to make sure they don't swallow it. We try to take every precaution with that. Yes?
What did you say is suing the FDA and the MAA?
IAOMT. It's an association that I belong to. And actually, IOMT has a conference.
IAOT?
IAOMT. They have a conference together with environmental medicine this year. So if you're able to, I mean, it's just fascinating to be able, and it's nice to get, just like today in this room, we have dentists and doctors, health practitioners. It's amazing. I think it's. I'm not for sure. If you go to IAOMT.org, I'm not exactly sure on what it is. So after all the mercury has been removed, we definitely recommend to patients, or we recommend them to a practitioner to help them with the mercury detoxification, because that's not something that we can follow through on. But one of the things we do recommend for them is actually some fiber to help them eliminate, right? We need to help them eliminate, because often we get reabsorption from the mercury. We try to eliminate it, but if your pipes, if your GI is not functioning.
Saunas are really good.
Yes.
Saunas when you detox
Saunas.
from it, yeah.
Infrared saunas? Yes. Very good for detoxification. You probably know all about organic and elemental mercury, and Dr. Tevan couldn't be here tonight. He's out in Russia having fun, but he gave me some slides to show you about biomimetic dentistry. And maybe the dentists here know about biomimetics, but it's a way to conserve tooth structure so that we're not cutting it away. That's really the point. The more we traumatize the tooth, the worse it is. So biomimetic just means lifelike, and it's basically creating or rebuilding the tooth in the most ideal way, like almost like the original, in the point where it's actually stronger than what it used to be. So what do we use for this? We actually use zirconia material as well as filling material that's filled with nanoparticles. So a tooth like this, you see actually has a fracture here on this side. What do we do with this tooth? If somebody has pain on biting, we're going to try to take away this metal, get to the point and see if we can get rid of the fracture line and try to save the tooth. So inside the tooth, a lot of times we see dark stuff, right? Bacteria that's essentially leaked underneath the filling, and this has to be cleaned slowly so we don't get to the nerve. And then we start to build the tooth in increments. Because if we put a whole blob all of a sudden, then it's not beneficial. And as he's building the tooth, then it starts to look more like its own anatomy. And this in itself is 8 years. It's an actual onlay, and you can see how it was cemented. You can kind of see the line, but we preserve the tooth structure. So inlays and onlays are just a healthier way to restore teeth. And we see them lasting a lot longer. This is the connection between the actual material and the tooth. What's mostly done out there, you have a large filling like the one you saw, we shave the tooth all the way around and a crown gets placed. But at that point, it's a lot of trauma to the tooth. So that's where biomimetics come into place. We say the pulp is the brain of the tooth. Okay, so when we remove the brain with a root canal, we say no brain, no pain, which is mostly the case. But when you see the crown here, what's the problem with the crown? You see the dark underneath the crown? That's actually a cavity forming where the crown meets the root. That's what it looks like. So, interesting, this tooth, cavity here, but where you have an actual enamel preserved, there's no cavity. So that's the goal, to keep the fillings and the crowns in the enamel edge, not all the way into the dentin. So we need to keep that line of enamel. That's the whole principle of the biorim, or in biomimetics. Cavity here where there's no enamel, and then no cavity where there's enamel. Because enamel is a very, very strong material. So, no biorim. Again, this is a tooth that's been shaved all the way around. So at that point, there's no more enamel. And then we put a cap on it, but it's going to leak at the edge. That's the issue, no biorim. That's how biomimetics works. It actually only cuts the part of the tooth that has the issue. So we preserve the enamel. So we only put a puzzle piece where that tooth structure is missing. We don't shave the entire tooth. So we preserve the enamel. That's the most important.
So how do you saying you don't shave it, but what if it has a crack in it? How is that?
Then we have to remove the crack. And that could be basically an elongation. You see how this restoration has a line going down? Mm-hmm. So we'll have to remove that crack and kind of make an extension in the restoration. Yeah. Sometimes when 90% of the tooth is gone, we'll still need a crown. But most of the times, so biomimetics is taught at USC. The guy who invented biomimetics is a USC faculty. So typically people who finish at USC, they learn biomimetics, but it's not taught in most dental schools.
Not yet.
No, not yet. But he does teach courses. Dr. Pascal Magna is his name. And he's started biomimetics almost 20 years ago. But it's just now becoming a little more popular, so to speak.
And you said it's made out of?
This that you see here, this is out of zirconia, actually. So it's a ceramic material. But you can also build it, we saw earlier, out of little composite material with ceramic particles.
So the zirconium was the metal, correct?
What's
metal
that?
That you showed? The zirconium was the metal that you showed?
Zirconia is actually the oxide, so it's white. So anything that you see white is ceramic. Zirconium would be the metal, but we don't use that at all in dentistry as a metal.
But you said this is made
Zirconia.
out of zirconia,
Yes.
which is
Zirconium oxide, which is a ceramic. Like aluminum is a metal. Aluminum oxide, it's a ceramic. I know, it's just...
It's like MMS. Do you know about MMS?
No.
It's chlorine dioxide. It's like, people think it's chlorine, but it's actually
Chlorine dioxide, exactly. Yeah, it's like that,
Maybe
exactly.
you should know about, because that helps a lot with oxygenation and clearing out.
I don't use it at all. Chlorine dioxide? Okay. I'll have to look into that. So, why is this working? Because adhesive dentistry, the bonding strengths of materials are so much better than they used to be. So, high bond, low stress, you get biomimetics. In the past, we didn't have these materials, so we couldn't do this. Meaning 30, 40 years ago. So we had to do crowns, we did metal crowns. This is what we typically see a day at our office, people coming in with mercury fillings, some cavities corroded. I mean, I haven't seen a mercury filling that's not corroded. They all corrode. So when this patient bites down and mercury fillings come in contact, they get galvanic current. That's what usually happens. Yes?
If there's mercury and metal in the tooth, does mercury hold enough structure to create a charge?
Positive to short
It does. Mm-hmm. Yeah, it does. So we take out the mercury and we see what's left. And then that's what it looks like after with the biomimetic reconstruction. Not with crowns, okay? This on the top is essentially some composites and some. We work mostly with Beverly Hills Dental Lab, who use biocompatible materials. They're like a mile away from our office. So some questions to ask your patients, or those of you who are doing something other than dentistry. Are your gums bleeding? Okay, that would be a sign that there's a problem. Do you floss or use a water jet regularly? Most people don't. But I have to tell you, only if you recommend them, like let's say their gums bleed and the only thing you do, you recommend them a water pick or a water jet, makes a huge difference for their health. Because water jets clean amazingly well. Do you have any root canals? Do you have missing teeth? Do you have loose teeth? That's a sign of gum disease that's untreated. If people tell you they have loose teeth, even though they don't hurt, that's advanced gum disease already. Metal fillings, bad taste in your mouth. A bad taste in your mouth can come from gum disease, can come from metals that are in the mouth. And do you clench or grind at night? We also want to know that. I mean, you would want to know that too. But this is one of my patients who tattooed his lower lip. I said, what? Read my lips. The mouth is really the number one source of unidentified infections. When we take a CT scan, and we've had the scanner now for a little over 3 years, we see infections that we don't see. And they go undiscovered. And thank you for sharing about the Alzheimer research about periodontal pathogens being found in the brain. And we know that there's biofilms and they travel. And detoxifying the mouth, it really helps the patient overall. It really helps the immune system, their well-being. And if you have any questions, please always, I'm happy to chat with you, or if you have a question.
What about oil pulling?
Oil pulling, good question. There's some studies on oil pulling that it helps with gingivitis. It helps with bacteria. So when you swish oil back and forth between the teeth, it becomes a soap after 20 minutes. So that soap can wash away the bacteria, but it doesn't go very deep subgingivally. So essentially, it's more efficient to use a water jet than to use oil pulling, because the water pressure actually goes in and scoops stuff out. And the oil pulling, I actually found a couple case studies where the oil droplets landed in people's lungs, and they ended up with like aspiration issues. Exactly. So I'm very careful. I don't recommend. I think there's better methods today to clean. The water jet works definitely. We have better studies with the water jet than I've seen with oil pulling. Mm-hmm. Yeah. Yes.
My favorite toothpaste brand that you like?
Favorite toothpaste brand.
What do you recommend to use?
I don't use a fluoride toothpaste. I don't think it's needed. I like to try different things. So I try different things, but I have a couple things that Biocidin makes a great toothpaste. I like it. It's very mild mint. Yeah, you like that one? You tried it? Yeah, very nice. Auromere, it's a little bit more herbal. Jason has one but they do with and without fluoride, so you can choose. But yeah.
We tried David's.
I haven't. David's toothpaste? I haven't tried it.
It is amazing. I just fell in love with it.
Okay.
I just bought it and gave it to people.
David's toothpaste.
It makes such
I have to
a
try it. So any other thoughts at all before we... Yes?
I just had a question on insurance coverage and payments for referrals to you in terms of the non-professional things you use and how that works out.
Oh, I'll let Carla answer that because she's the expert with insurance. So, yeah.
We're a fee-for-service practice, but we will assist in...
You're asking if it's covered, right?
What is covered, and then,
Yeah.
We'll try to get the highest reimbursement for our patients, so as a courtesy, we'll still file the claims for them. And we'll use specific codes, even though we're using like ozone, which isn't typically covered by insurance, we'll use specific codes that will be covered. And we'll just provide narratives, and you usually get, as much as insurance does reimburse you, to our best.
And then on another topic, it just seems that like an oral probiotic rinse would work best than like internal things. And I don't know if you've ever experimented with like breaking up the capsules and having patients do that versus.
Yeah, that's a good. Actually, I'm working on making a powder right now.
That makes sense.
Yeah, to make a powder to dissolve it and actually swish with it. I'm the founder of Orasana. Some of you might know, and We started with probiotic chewable mints, and I was doing some small studies in my office. But I agree with you. I think swishing it back and forth, or maybe even adding it in a water jet, we'll see how that works. I mean, we don't have any studies on that yet, but it'll be interesting. Good thought.
What is
Yeah.
what is your detox protocol then, if you're removing mercury fillings or amalgams? What do
We
you-
usually work with a practitioner, but for us, usually our patients come already from an integrative physician that's following up. But all of them have said, remove the fillings first, then we start the detox.
You don't know what that is specifically, the protocol?
Everybody has something different. Everyone. It does include infrared saunas. It does include chelation. Some people do IV chelation. Some people are against IV chelation. So I don't know. I have not seen one thing that's repeated.
Yeah, so is there any good studies that provide information about that?
I think there are good studies with I don't know if you guys do, if anybody does mercury detoxification, about studies on how to detoxify from it.
No, but there are studies. I mean,
There are, yeah.
IVDMPS, the patients have a million side effects to them.
Quicksilver has a package that they sell to the public
That's right.
for mercury chelation. I don't know how effective it is, but it's a good place to start.
But you can do like the oral DMSA protocol where you take it every 4 hours, but it's a hassle for the patient. They have to wake up all the time, take it.
And it's intense.
It's very intense.
So you need to have you need to do some healing before to try to get more to have fewer leaky boundaries, like in your gut, your brain, your lungs, your blood vessels. So start with some helpful work, get your teeth cleaned, and then do a little more cleanup, and then you can always do more IV later.
Exactly. The DMPS every 2 or 3 weeks. You have to take minerals with it. There's a lot of things you need to do.
Yeah.
I usually say 6 weeks to 3 months of detox before they even get their teeth cleaned.
Okay. Yeah.
You know, to ask for their system to like detox a massive burden on an already burdened system, it's trouble.
Yes.
So going,
I see what. Yeah, sure.
for it.
To make sure the detoxification pathways are open. Yeah, that's
And there's
important.
some integrity.
Yeah.
So I have a question. What's the blood level? Like I realize under the 10 is considered application 11 she get very nervous. I mean, how much you think is really serious?
Is this provocation test or what is it? Blood mercury?
Yeah, in the blood.
The doctor's data testing, which test we do?
As a blood test, I don't know.
The blood tests to me aren't accurate because it only stays in your blood for so long and then it leaches out and goes into your tissue.
What's
So I
the
don't
time that's
consider it provocation.
Oh, you're but in terms of the mouthwash, do you recommend it for there's a daily mouth rinse? Any good products for that?
For just
For prevent the
for inflammation?
Yeah.
So, we want to maintain a good microbiome. So I don't recommend mouthwashes unless there's a problem. Once in a while is okay, but we don't want to be too antiseptic. So it depends on the mouthwash, right? What kind of mouth? I don't like strong antiseptic mouthwashes unless there is inflammation. I think that we can take good care of, by brushing, flossing, taking care of your microbiome without using additives. Mm-hmm.
One of the actually among people folks I heard, I don't know if it's right or not, like people using a little bit salt. Like in the toothpaste, put
Salt?
a little bit salt to brush the teeth.
Okay.
Is this a good idea or no?
I don't think salt necessarily does anything. If it's maybe mineral salts, it might help with minerals, but that should be ingested mostly, not necessarily applied on the teeth. I don't know of any studies that salts are good.
Scratcher now.
Right. So I'm not sure what they do it because of they like salt flavor or
It's sort of antibacterial.
Antibacterial.
It doesn't really, leave it. I don't know.
yeah, exactly. Most people don't brush where they should anyway. If you just brush the teeth, it kind of doesn't get where you know.
It's also a desiccant, so you're
Yeah. Exactly.
Do you guys know about diatomaceous earth?
Diatomaceous earth, only for gardening,
Algae.
but
Yeah, they use it for gardening
Uh-huh.
as well. but that would be better than the salt because even
To add
that
in the
is a
toothpaste.
little bit harsh, but it's not. It's very soft. It's nothing like salt, but it's much better than.
To put it with water?
Yeah.
Dr. Schultz, Richard Schultz, he has a good formula. It's pretty intense, but it's a great formula.
Dr. Schultz for gingiva?
No, for mouthwash.
For mouthwash.
Really
I
powerful.
tried, he has some drops or something, and they were so spicy. He has some spicy drops for the water jet.
He's a
It
radical.
was a little too strong, I know, yes. Again, I think, of course, diet is the base of everything, right? So we always talk to them about diet and lowering the sugar and fiber.
And carbs.
And carbs.
Carbs convert into sugar.
Yeah, exactly. Sticky foods, those are bad for the teeth. So acidity, lemons, things like that. So anyway.
Thank you.
Thank you,
Thank you.
Michelle. Thank you to all of you for coming tonight. Thank you.